a topic that is dear and dear to my heart, being a pediatric nephrologist, childhood nephrotic syndrome, but I think it has great relevance to both undergrad and postgrad people with regards to this relatively common kidney disorder that you see in children. The one thing that I wanted to see is that, so if I want to ask questions and make it interactive, would people like to answer, join in? How do you want to proceed with this?
Either way, sir, your wish. You can ask questions, sir.
Perfect. That's exactly what it should be. I think it's an undergrad lecture, be fairly interactive. So while we have used images for teaching, a lot of them are covered by copyright. So I think we cannot use it for publication. So we'll start off with a case. So this is a 4-year-old child who is presented with a 3-week history of progressive edema that involves his eyes and feet. His past medical history is normal. On physical examination, his blood pressure is okay. He does have some edema with the scrotal area as well as some pitting edema up to the mid-calf area. And a urine dipstick shows 4+ protein. So really the focus of this lecture is to really see what he has and how are we going to proceed with this. Okay, so we'll come back to this question, but what he has that stands out to you is the fact that he has some edema, right? Sorry, let me go back. Let me see if I can make this as a pointer. Okay. So what he has is pretty much some edema as well as proteinuria, right? So this leads us to think of what he has, and then we come to this definition of nephrotic syndrome. This is a constellation of findings of nephrotic syndrome, and this applies to either childhood or the adult variety of nephrotic syndrome. And what we have is heavy proteinuria, hypoalbuminemia, edema, and hyperlipidemia. So we will look at each of these features separately. So let's look at proteinuria. So how do we detect proteinuria? We usually detect proteinuria by using a dipstick. We look and see when you dip the urine what you get, and this is multiple things that come out. You start off, and that's protein here, if you can make out, and that turns out to be this color. Okay, so it's a colorimetric change, and with that we know it is positive, and depending upon how deep the color is, you can grade proteinuria from trace to 4+, 4+ being the highest. So what is the clear disadvantage of using this? Can anyone chime in? Why would a dipstick be not a great way of looking at proteinuria?
Sir, it's specific for albumin.
Naturally, I think that is an albumin that you have. This actually is proteinuria. So that is a good point. So some of them are specific for albumin, and that's called as an albustix. But this one detects all kinds of protein, not just albumin. But that could be a disadvantage, meaning if you want albuminuria versus other proteinuria.
Yes, spot sample, sir.
So the reason why we go to a quantification of a spot, and this is the spot sample, is because anything in the urine could be affected by concentration, right? So if you have a very concentrated specimen, then even having mild proteinuria can appear very high. It could be magnified because of the concentration. And if you have a very dilute urine, even if you have heavy proteinuria, it may not be picked up. So how do we detect concentration? We detect concentration by creatinine. This accounts for concentration. So somebody who has, you do a spot protein and you correct it for creatinine, and that way you correct for concentration of urine. So if that is more than 2, normally it should be normal is less than 0.2. Okay, if it is more than 2, then it is heavy proteinuria. We can do a 24-hour collection, and for older children and adults, it's commonly done. And if you have more than 1,000 milligram per meter square per 24 hours, then you call this as heavy proteinuria. Okay. So why do we get proteinuria in nephrotic syndrome? For this, we go to the glomerular filtration barrier. The glomerular filtration barrier, if you go back to your, maybe about a couple of years to pathology and look at the glomerular filtration barrier and sort of dumb it down, we have 3 layers, right? One, this is the blood side. This is the blood side. And there you have the capillary lumen. It is covered by these endothelial cells with tight junctions in between. That is the first layer on the blood compartment. Then you have the second layer, which is the glomerular basement membrane. And that glomerular basement membrane is made up primarily of collagen, but it can also be other things that go in, like nitrogen, laminin, heparan sulfate, and other things. And then when you go to the urinary space, you have epithelial cell layer, which lays out these food processes. And these food processes are called as podocytes. Okay, so that is our hero today. And if you really look at a magnified view of the podocyte and a pictorial representation that's here, what we see is that you have podocytes, and in between the podocytes, you have what is called as a slit diaphragm. Okay, and that slit diaphragm is actually made up of almost a zipper-like fashion by interdigitating proteins called nephrin and podocin. And why this is important is because in rare genetic conditions of nephrotic syndrome, these are the proteins that are affected. So that slit diaphragm, if it is disturbed and if the podocytes are disturbed, you start losing protein. Okay. Any questions in this part? I think this is sort of going back into a small area of physiology, but I think it is critical if you're looking at proteinuria. Are we good? We can move forward?
Yes, sir. We can move forward.
Right. So this is what we see by a cartoon of what happens in nephrotic syndrome. This is, if you look at, if you imagine that these are the podocytes, all these Hershey's kisses arranged nicely with all these podocytes, and if they become flattened, then you start losing protein. Okay. And if you actually look at an electron microscopy, this is one of our patients where you have normal podocytes are upright, nice and upright, and then you have the slit diaphragm that you can actually see in between. What happens in nephrotic syndrome is these upright food processes all become flattened. You can see that all through. So if you have diffuse effacement or flattening of the food processes, that is characteristic of nephrotic syndrome. So why do you have hypoalbuminemia? If you have heavy proteinuria, your albumin falls, which is the main protein that is lost. You have to have serum albumin level of less than 2.5 grams per deciliter. And it's important to pay attention to units in nephrology. In some labs, it could be reported as 25 grams, less than 25 grams per liter. So always pay attention to units. In chemistry, pretty much chemistry interpretation, and we nephrologists deal with this all the time. So it's very important. Edema. So edema, and this is an example of a pitting edema in a child with nephrotic syndrome. Why do we have edema? Probably the most important cause in children is the underfill theory. The underfill theory means if you have low serum albumin, that causes low oncotic pressure. And if you have low oncotic pressure, then the fluid shifts to the interstitium. If the fluid shifts to the interstitium, you start having edema. Of course, in addition to that, because of intravascular volume depletion, you have activation of the renin-angiotensin and aldosterone system, and that causes salt and water retention as well. In adults, you do have some overfill where there is impaired natriuresis and diuresis due to whatever reason it is, increased plasminogen and other things. And that causes increased intravascular volume and salt and water retention. But the most important thing in children we see is the underfill component with intravascular volume depletion. Okay. Hyperlipidemia happens because of two pathways. Both the pathways, you have increased production and decreased clearance. So if increased production happens of cholesterols and triglycerides, primarily limited to LDL and VLDL. And then there is decreased clearance because of reduced lipoprotein lipase activity. So that leads to increase in LDL, VLDL, PGL, but unchanged HDL cholesterol. Okay. So those are the 4 characteristics of nephrotic syndrome and why it happens in nephrotic syndrome. Any questions thus far?
No, sir.
Very good. Okay, great. So next, let's look at how do we classify nephrotic syndrome. The way we classify nephrotic syndrome is either primary nephrotic syndrome or secondary. Secondary is due to multiple causes. It could be infections like syphilis, HIV, or hepatitis, and even malaria. I think Plasmodium malaria can cause nephrotic syndrome like picture. Drugs, and the drugs are listed, bisphosphonates we've seen, and then malignancy, including leukemia and lymphoma. And sometimes you can see it, we've seen it actually with Hodgkin's lymphoma, where you can have nephrotic syndrome as presentation. So that is the secondary cause. Now we'll focus on the primary nephrotic syndrome, which is probably the focus of this lecture. Primary nephrotic syndrome, the most common cause of childhood nephrotic syndrome is minimal change nephrotic syndrome. Let's make that clear. So that is an important teaching point you got to remember. In childhood, it is minimal change variety. The other condition that can happen is FSGS, which is focal segmental glomerulosclerosis, and that happens in about 10 to 20% of childhood, but increases in its incidence as the age advances. The most common nephrotic syndrome in adults is the membranous variety. Okay. You can have other causes of glomerulonephritis like lupus presenting as nephrotic syndrome. And then about 10% of cases of childhood nephrotic syndrome is due to genetic causes. And that genetic causes, it goes back to those slit diaphragm proteins we talked about, nephrin, podocin. If there is a genetic defect in those proteins, then you end up with congenital or infantile variety of nephrotic syndrome. And I think much more of this early onset nephrotic syndrome, we are finding genetic causes. Okay. So we come back to this, child who had presented to us with swelling and proteinuria. Now you think he has likely nephrotic syndrome. So what is the next step in proceeding? It's always history and good exam, right? So this is important. We got to get a blood pressure with the right size cuff. And why is that important in pediatrics? Can anybody chime in? Why is the right cuff important in pediatrics? All of you go to sleep? Is it too early for sleeping? What is why is the right cuff important?
So a larger cuff area might show an increased pressure falsely.
Sorry, it's the other way around. So a smaller cuff will give you an increased blood pressure, and a larger cuff may show you actually a decreased blood pressure than the actual measurement. Okay, so it is critical that you have to have a good cuff size. And that is, I think, one of the most important things in taking blood pressure in children. Have to make sure that the cuff is, the bladder of the cuff is at least 2/3, it covers the arm circumference. Okay, and particularly with obesity that we are seeing, we got to make sure that we have to upsize the cuff. If you do a smaller cuff, if you do a small child-sized cuff in an obese, say 80-year-old, you're going to get higher blood pressures. So it's important, and it's a good important pearl to remember in pediatrics. So other things are, you have to think about medication. We talked about all these are the secondary causes that you have to look and see is for all the secondary causes of nephrotic syndrome. Then lab you do, you look at take a UA, look at proteinuria, and then a BMP, which usually includes electrolytes, B1 creatinine and calcium, albumin, complement, particularly complement C3 level, CBC, lipid panel, and PPD. Okay. I'm going to say the most important thing right after history and good physical exam in a nephrology practice is looking at urine through a microscope. And I think that is critical that we have to do. Why is that? We will come to that in a second. Because you can make this important differential diagnosis with just a good microscopy. So you have nephrotic syndrome, and we talked about minimal change being the most common cause. You can have nephritis, and post-infectious nephritis is the most common cause. What is the most common infection that causes the nephritis in children?
Beta hemolytic streptococcus.
Exactly. So it is post-infectious and it is post-streptococcal glomerular nephritis, and it is still probably the most common cause. We do see other infections, but that's probably the most common cause. What you see with just the color of urine is that you do get gross hematuria. So you get a tea-colored or a Coca-Cola colored urine with nephritis, glomerular nephritis. Generally in nephrotic syndrome, it may be dark, but you don't have gross hematuria. AKI is not common actually in both, but you do much more AKI you see in nephritis when compared to nephrotic. Hypertension, this is I think a very important entity that you see in nephritis. And this goes back to our original theory of why we had edema in nephrotic. We talked about the fact that in nephrotic, you have intravascular volume depletion. However, in nephritis, you do have overfill. You have intravascular volume overload because of impaired natriuresis and decreased GFR. And therefore, because of increased intravascular salt retention, you get hypertension. Okay, this is a very important thing. The way you differentiate, if you have hypertension in somebody who has a dark colored urine, you're going to go to the pathway of nephritis. A microscopy, a urine microscopy in nephrotic, you can see oval fat bodies. You can see microhematuria in about 20%, and occasionally you can see a hyaline cast, but you do not see a very active urinary sediment. And that's what you see in nephritis. You see a lot of RBCs, which are dysmorphic. You see cast, and the red cell cast is pretty much diagnostic of glomerular nephritis. Complement levels are normal in nephrotic, low C3 in post-infectious GN or post-streptococcal GN, as you see. That I think is critical to remember. Management is symptomatic in nephritis, but we'll talk about it. It's steroids is the most important thing. Relapse is pretty uncommon in a post-infectious glomerular nephritis, but fairly common in nephrotic. So that's an important differential diagnosis. Once you've arrived that this is nephrotic, you got to see whether this is nephrotic or nephritis. So this is the urine microscopy. And these are the oval fat bodies, okay? Do you know what was the original name of minimal change disease?
Lipoid nephrosis, sir.
Exactly. It was lipoid nephrosis. And you know why? Because you saw all these fat droplets. So you saw fat droplets in the urine. This is a UA that you see, oval fat bodies of fat. This is pretty much fat droplets. And even in the biopsy, in histology, you could see some fat accumulation. And that is why it was called lipoid nephrosis. Good. So if you see under the microscope, and this is actually because of the talk that I got a UA picture through my iPhone for one of these nephrotics that I saw in the clinic. So what you see, this is a nephrotic. You see occasional microscopic hematuria, and that is a hyaline cast that you see. And that is an RBC that you see. What is one peculiar feature of that RBC? I don't know whether you're able to see it well or not. Is your border smooth there? It's not a round border, right? So you don't see it a perfect round like this. You see those crenations, what I call as Mickey Mouse ears that are protruding out of the border. And that means that's a dysmorphic RBC. And that means it is an upper tract microscopic hematuria. And as I said, in about 20% of cases, you can get it. This is an opposed to a nephritis that we saw in the clinic. So that is a nephritis. Do you know what this is? What cast that is?
Granular cast?
That's actually an RBC cast. You can see all these RBCs. Good try. You do have cells, but these are RBCs that are there. And similarly, can you see that RBC cast right here? And this is a granular cast. And you have a lot of RBCs as well, as you can see all these areas. So this is a pretty, and here as well, almost a dumbbell shape you can see, and that's a crenated RBC. And that's another crenated RBC. This is a perfect example. That's I think, a perfect example of a crenated RBC. You can almost see that Mickey Mouse here protruding out. So that is this is clearly a nephritis, a pretty active urinary sediment. Okay. Any questions thus far? Are we good?
Yes, sir.
Okay, great. So the other lab findings, we talked about this already, the first one, and the second point, serum sodium can be low. Okay. Why is there increased ADH in nephrotic syndrome, in spite of serum sodium being low? Can anybody attempt? Let me back off and ask you, what are the two stimuli for ADH? This is physiology.
Increase serum osmolarity.
That shuts off, right? Yeah, increase serum
And
osmolarity.
decrease
Perfect.
intravascular volume.
So perfect. So the way if you have increased serum osmolarity, right? However, serum osmolarity is contributed by sodium, right? So if you have a low serum sodium, this should have been cut off. But absolutely you're right. When you have volume depletion, when you have decreased volume, then ADH gets up, right? And that overrides this earlier condition of decreased serum osmolarity. You would think that when the sodium is low, ADH should be shut off. That doesn't happen because you have intravascular volume depletion. And that makes the sodium even lower and causes dilutional hyponatremia. Serum calcium may be low due to hypoalbuminemia, but ionized calcium is normal. This is, again, very important pearl to remember. Do you know why? Why is this?
The calcium is bound to albumin in the blood.
Perfect. Absolutely. Absolutely. About 45% of total calcium is bound to albumin. And therefore, if your albumin is low, then your serum calcium, total calcium is low. You can measure an ionized calcium, which is normal, or if you have an albumin, you can correct it by 0.8 times the difference. And that is called as the corrected calcium. And it's important to do that in nephrotic syndrome. Your hemoglobin in hematocrit is elevated because of volume contraction. You can have thrombocytosis. You can also have true calcium losses in some conditions because there is urinary losses of vitamin D3. Okay, right? Any questions regarding this? Are we good? So next step, the natural history of epidemiology. So we talked about minimal change. We call it as minimal change because the only change that you see on a biopsy would be ultrastructurally in the electron microscopy findings of effacement of food processes. Otherwise, you do not see any change in light microscopy, and the immunofluorescence microscopy is normal. Okay, that is why it is called minimal change nephrotic syndrome. Remember, the nephrology as a distinct entity came into being after discovery of two things. One, we had renal biopsies, and two, microscopy. So a lot of kidney disorders are described by what we find in microscope. So minimal change means there's not much change in the microscopy. And that's how the name stuck. And you can see it, focal segmental glomerular sclerosis means you see some sclerosis in some of the glomeruli. So this is purely descriptive diagnosis. So the peak age is about 2 years. 60 to 70% occurs within 6 years. So most of it is pediatric, pretty much, in this minimal change. High incidence actually in the South Asian community, and this has been shown in multiple cohorts of patients. A lot of work from 6 Children Toronto to describe this, this variation that we see. There is a male preponderance, and this is, I think, an important teaching point, and we'll come back to this. Initial steroid responsiveness in about 80 to 85%. And that is, I think, very important to remember. Why do we have it? We actually do not know for sure, but we do know that there is an alterations in podocyte biology. So it is called as a podocytopathy. Yeah. So it could be because of alteration of T, B, or a primary podocyte dysfunction. T cells, ever since the experiment of Shalab and others, we know that T cell disturbance can happen in nephrotic syndrome. We know that certain conditions with energy, like measles, induce remission. Hodgkin's alters T cell function, and it's associated with this. Clearly, drugs such as steroids can cause remission. Iduro B cells are also could be affected. We have some elevated levels of CD23. Rituximab does work, and that is a relatively recent discovery. We also know that there is primary podocyte dysfunction by means of elevation of certain podocyte proteins. And certain medications, including rituximab, has a direct effect on podocyte cytoskeleton. So it could be a combination of all this, but it remains to be discovered of why we get minimal change disease. So again, we come back to our 4-year-old. We know he has nephrotic syndrome. We have the labs. We've confirmed that he has nephrotic syndrome. And by natural history, we think this is minimal change disease. So how do we first, not definitely, but how do we first manage? We manage because he has come in with a lot of fluid, a lot of edema, right? So how do we treat this? We treat this by salt restriction. So normal salt, this is, I should have put, actually, my bad, not salt. It should be sodium restriction, okay? It's sodium restriction. So normal requirement of sodium is about 3 to 4 millicoulomb per kilo per day. You give about 70%, about 2 millicoulomb per kilo per day. Fluid restriction, normal maintenance is about 1600 mils per meter square for patients, about 70% of that. And then you can use diuretics, but you have to use it with a lot of caution, okay? You do have resistance of diuretics, even the high ceiling diuretics like furosemide and bumetanide. And that is because both furosemide and bumetanide, both these are protein bound, and therefore they do not get to the site of action of how where they have to work, okay? Where do loop diuretics work?
So sodium chloride transporter.
Correct. Sodium 2-chloride transporter in the loop of Henle, right? So they're called as loop diuretics for a reason. They work in the loop. So, but important thing, a lot of these, remember, the diuretics work from the luminal side, okay? So they get secreted into the proximal convoluted tubules by the organic anion transporters, through the organic anion transporters, and then travel via the lumen to the loop and act from the lumen within. They do not get from the blood to the site of action, from the loop directly into that 2-chloride channel, which faces in the luminal side. And they have to get there, and that means they have to be secreted from the proximal convoluted tubules. And if they are free form, they're not bound form, then they just get filtered off and get destroyed. So you don't get Lasix going to the site of action. Increased volume of distribution happens because of expanded interstitial compartment. And you have a lot of other urinary proteins that sort of binds it and takes away the free active drug from the site of action. So how do we counter this? We counter this by increasing the dose, but most importantly, you can combine it with 25% albumin. And that way you preserve the bound form right at that time, and then you have delivery to the site of action, okay? You can combine it with distal tubular diuretics, and we do combine sometimes with metolazone in these patients to have enhanced activity. And in some cases recently, we've used amiloride because there is decreased ENaC activity as well. But it is very important to remember that you have to use it very cautiously, because what we see in childhood nephrotic syndrome is already a state of intravascular volume depletion. So if you use this more and aggressively, you could cause much more AKI, much more acute kidney injury. So you really have to be careful. You can cause, because of the volume depletion, you can cause thrombosis. Obviously, you can have electrolyte disturbances, so as we have listed. And sometimes if you have used it for a prolonged period of time, particularly the loop diuretics, you can have hypercalciuria and nephrocalcinosis. Okay. Any questions? I move forward then. Do we biopsy? In a childhood nephrotic syndrome, not routinely, we do not. So the indications of biopsy in a childhood nephrotic syndrome is what I've listed. If you have something that doesn't fit the bill of a childhood nephrotic syndrome, if you have gross hematuria, marked hypertension, renal failure, which cannot be explained just by hypervolemia, low complement level, or if you have an obvious secondary cause, and then once you've treated, if you have steroid resistance, or you don't again fit the bill if you're more than 12 years of age. I don't think I would biopsy anybody more than 12 either. I could try medication and see until they are in the pediatric age group, and our pediatric age group is up to about 18. And then less than 1 year, a lot of times we are first going to the genetics to make sure that this is not a genetic cause of nephrotic syndrome rather than a biopsy. Good. Are we good with the indications of biopsy?
Yes, sir.
Good, very good. So what is the routine treatment? For undergrad level, I think the most important thing for you for med school to remember, it is steroids. And it is high dose steroid given for 2 milligrams per kilo for at least about 4 to 6 weeks daily. So those are the important things to remember, okay? It's a single daily dose, 2 milligrams per kilo, 4 to 6 weeks. And then you switch it over to an alternate therapy for another probably 4 to 6 weeks, okay? This is a KDIGO guideline that came out in 2012, talk about tapering. But there is a recent randomized controlled trial which said that there was not a big difference between both. So giving it 6 weeks and 6 weeks, that was shown by the German group to be effective. So that's what we do. But whether you taper it off or not, it's up to you. I think we have good studies which show you can just abruptly stop. So this is important to remember what happens after. So what is the course of nephrotic syndrome once you've started steroids and given them the full treatment? Either they can go into complete remission, where you do not have proteinuria, and we have that for at least 3 days. Or you can get resistance if you don't, if you have 8 weeks of therapy and you don't respond, okay? You can have, and as we talked about before, relapses are common. What do you call relapse? Relapses, if the urine protein is more than 2, or more than 2 plus, or a protein creatinine ratio of more than 2 for 3 consecutive days. Frequent relapses, that if it happens 2 or more within a 6-month period, or more than 4 in a 12-month. And if you cannot get off steroids, or you come back within 2 weeks, we call it a steroid dependence. Okay. This is how once you are classified as a childhood nephrotic, what happens with your course, we define these by these definitions, well accepted. Again, these are from KDIGO guidelines in 2012. So with that definition in mind, let's see what the natural history is. The natural history is steroid responsive state. 80%, almost 75 to 90% of childhood nephrotic syndrome is steroid responsive. They do relapse. And in fact, they commonly have frequent relapsing nephrotic syndrome at about 60%. Steroid resistant nephrotic syndrome happens in the 20% of childhood variety. Okay. Treatment of relapses, you treat again with steroids, but do it as a shorter course, and you got to balance steroid toxicity while achieving remission. Okay. And if you have very frequent relapses, you start having steroid side effects, then you can use steroid sparing agents. I've given you a brief overview of what that is. These are the alkylating agents, cyclophosphamide and chlorambucil, which is one course, but you cannot give it more than one course because you will start having cumulative gonadal toxicity and bone marrow suppression. So you just give one course for about 12 weeks. Calcineurin inhibitors, and this is where you have things like Prograf, tacrolimus, or cyclosporin. This has to be continued for a while, and that is true for all three: calcineurin inhibitors, levamisole, and MMF. It is not a short course; it's about a 12-month course that you do. Minimal side effects of levamisole, which is an immunomodulating agent. Unfortunately, it's not available in the US, but we've used it when I was in India. So we have used levamisole. Rituximab is the newest entry into this armamentarium, and that you use once weekly for about 1 to 4 doses. And it's important to remember that long term you can get infection, so you have to be careful while using this. And we have now, I think there is a wonderful randomized control trial that came out in JAMA Paediatrics about 1.5 years ago from India about the use of rituximab in steroid-dependent nephrotic syndrome and being effective. But I think it needs repeated doses, and we are discovering that as we move forward. Okay. So you have this 4-year-old. Now he has gone into remission after treating with steroids, and 6 months later, he's come in with all these symptoms. He has abdominal pain, fever, rebound tenderness. He has a relapse. You do a paracentesis. You see WBCs. So what is this complication, and what is the most common etiology? You can take a stab at this. What do you guys think? What does this child have? He has abdominal pain. You do a paracentesis from the ascitic fluid, and you see WBC. So what do you think he has? No takers. Okay. Yeah. What does he have?
Most common etiology is pneumococcal infection.
Yeah, you're right. I think you're going in the right direction. It is a pneumococcal infection. And what is it called? It's
spontaneous bacterial peritonitis.
Yeah, exactly. It is a spontaneous bacterial peritonitis. Absolutely. So infections do occur with nephrotic syndrome. And you have low serum immunoglobulin levels, decreased levels of complement B, and therefore it causes decreased opsonization. And opsonization is important for encapsulated bacteria, including pneumococcus. Edema is a good culture medium. And you are on immunosuppressive therapy on and off, so your immune system is low. So you do get infections. Okay. The turn of the century, starting in 1900s or so, do you know what was the mortality of childhood nephrotic syndrome? Anybody take a guess? You take a guess.
2.4%.
How? What was it? Sorry, I didn't hear you. Let me spare you. So it's about 50% was the mortality. Okay, 1 in 2 children died with childhood nephrotic syndrome. Okay, and that was all due to infection. The current mortality is less than 5%. Okay, and that's because of only 2 things. One, we serendipitously discovered about steroids. But more importantly, we have good medications, we have good antibiotics to treat infection. And that's what happened. This happened primarily because of antibiotics. So if you take care of infection, a lot of your mortality is taken care of, okay? It's important to remember that. So you're right, this is spontaneous bacterial peritonitis. You diagnose this if you have your polymorphonuclear count, more than 250 cells in a tap, more prone for infection of strep pneumo, and that is a very important thing to remember. Strep pneumo infections, you can get E. coli. Other infections such as cellulitis of the skin is also common. You gotta think about it, particularly if you have a lot of edema and if you have a weeping skin lesion, then you can get cellulitis. That's important to remember that, okay? So now you have another child who is a 9-year-old with frequent relapsing nephrotic syndrome. He has come with persistent headache, drowsiness. He does have relapse of his nephrotic syndrome with increased periorbital leg edema. This is your exam. You have a altered mental status with Glasgow Coma scale of 10. You have sluggish withdrawal to pain, no response to the right leg. Deep tendon reflexes are equal, okay? And this is the CT, okay? So what could happen here? Any guesses? This is an infarct area, right? This is an infarct area in the left side of the cortex, which is why you have right-sided findings. And then when we do an MRV, actually, this is what we saw. So this is where you do not have a lot of these. You have voids in all this venous pattern distribution of the dura. You see there's a void here. You don't see anything as opposed to this side. No venous. And similarly, voids all along. Okay. So what you have is a dural venous sinus thrombosis. Okay. So extensive dural venous sinus thrombosis is one of our children who presented with this unfortunate complication. That brings us to the question that you do have even in childhood, but much more in adult. If you have continued nephrotic syndrome, you can have thromboembolic complications. Most of them occur with an initial diagnosis, and that is because you have loss of anticoagulant factors, and that's antithrombin 3 and protein S, and there is increased production of procoagulant factors. You do have aggravating factors, like if you have a central venous line, immobilization, and I should probably put intravascular volume depletion. So that also is an important entity, and we talked about that when we talked about diuretic use. So that makes them prone for having thromboembolic features. Thankfully, in childhood nephrotic syndrome, this is a rare entity because you don't stay as nephrotic for a long time. But if you have prolonged nephrotic syndrome, then you definitely have to be thinking about thromboembolic complications. Okay. So any questions regarding complications of nephrotic syndrome? If not, we can move forward. This is an important thing for pediatrics. So when do we immunize these children, particularly with live viral vaccines? If you are on a high dose steroids, then you have to wait until about a month after discontinuation. If you are on lower dose steroids, you can think about live viral vaccines. And that's what we have said here. If you are on medications other than steroids, things like cyclophosphamide or calcineurin inhibitors, or even rituximab, they have to be deferred for 3 months after therapy, at least 3 months after therapy. And then rituximab, it gets even longer until you have reconstitution of B cells. You do not want to give live viral vaccines. All these children should complete pneumococcal vaccination. Okay, and that is very important preventive medicine that we have to do in these children, primarily because they have such a high complications with the pneumococcal infections. Okay. So what is the outcome? And this is looking at the sort of the big picture outcome. 80% of all childhood nephrotic syndrome, we talked about this being steroid sensitive, right? And if you take those 80%, 30% of them just get one time of this nephrotic syndrome and then go away. But unfortunately, the rest of them do relapse of that 80% who are steroid sensitive. And then about 40 to 60% have a frequently relapsing course, which we defined as more than 2 in a year, 2 in 6 months or 4 in a year, 20-30% of infrequent relapses. And these you can treat with steroids and eventually it'll go away by about 8 to 10 years or so. 40 to 60% of relapsing nephrotic syndrome continue to relapse. Only 3% develop CKD. And you do have adult recurrences in this category. And less than 5% can develop late steroid resistance. They also end up in CKD, chronic kidney disease. So for the majority of childhood nephrotic syndrome, do not have chronic kidney disease. They do relapse, but they respond to steroids. And eventually they could burn out by about 8 to 10 years of the disease process. Okay, so that is the outcome for most of the childhood nephrotic syndrome. Okay, so that comes up to our pretty much our last slide, I think. So this is regarding how do we define nephrotic syndrome, right? And how do we define nephrotic syndrome? Somebody has to answer. I'll put the 4 things. Go ahead.
So heavy proteinuria, hypoalbuminemia, edema, and hyperlipidemia.
Perfect. Edema, low albumin, and then increased cholesterol level. Perfect. So those 4 constitute the definition of nephrotic syndrome. What is the most common cause of nephrotic syndrome in childhood?
Minimal change disease.
Minimal change disease. Minimal change disease. Very important. Please remember that. Minimal change disease. What is the most important prognostic factor in childhood nephrotic syndrome? What decides the fate of these children?
Steroid response.
Absolutely. It is steroid responsiveness. It is absolutely. It's steroid responsiveness. And that decides how you're going to behave, right? Steroid responsive, likely you're going to go, you may have relapses, but eventually you will not be left with chronic kidney disease. What is the most common immunosuppressive therapy that is used? Sort of it's a DA movement, right? It's steroids, right? Steroids. And always remember about infection as a complication of nephrotic syndrome. Okay? Spontaneous bacterial peritonitis. Absolutely. Spontaneous bacterial peritonitis. Good. Questions? Any question? I've got about maybe 6-7 minutes. Any questions about childhood nephrotic syndrome? Any questions about any pediatric nephrology questions? Anything that you got? You can ask. Now is the time.
So can you tell us lipid profile, like which on VLDL, HDL all increases or?
Sure. So what happens with, I can put it right here. So what you have is increased LDL, VLDL, okay, increased triglycerides, and almost non-altered HDL is no change. That's what happens, okay? So actually when you measure lipid in a lab, what you're going to get is HDL, okay? And then sometimes you get non-HDL, okay? They actually derive these there, unless you have a chromatography lab, you will just derive these. So non-HDL levels will be high, triglyceride levels will be high.
Thank you, sir.
No problem. Anything else? One thing I wanted to ask, were you able to see the things that I wrote on the slide?
Yes,
Yes,
sir.
Or no?
sir.
Yes, sir.
Yes, okay, right, perfect. I don't want to make sure, hopefully it came through. Anything else? Any other questions? As I talked about just nephrotics or anything in pediatric nephrology, happy. As I said, I have another.
Patient present with different FSGS like presentation. Is treatment is same as minimal change disease?
Oh no, not at all. So FSGS. So great. So good question. So FSGS, the way we differentiate. Let me pick up a. I should have a whiteboard. Then it's easy for me to write. Maybe here. Okay. So if you're not steroid sensitive, right? So if you have FSGS, not all FSGS is. Let me do this. Sorry. Make sure I got a pen here. Okay. So not all FSGS is steroid resistant. Okay, that's important to remember. So some are steroid sensitive as well. If you're steroid sensitive, then you do not biopsy and they just follow this route. However, if you're steroid resistant and you do a biopsy and you get FSGS, okay, then the way we treat is that we will not use cyclophosphamide. You would stick with either calcineurin inhibitor, okay, as a therapy, along with pulse steroids. Okay, so those are the two things that we use. It is sort of a we call it as a Thun-Mendoza protocol, a modified Thun-Mendoza protocol. We use calcium inhibitors. You can use mycophenolate mofetil as well. Unfortunately, about 30 to 40% of that FSGS does not respond to any medication. Okay, and they progress on to have CKD. Okay, so few important details about FSGS. FSGS is a histological sort of a descriptive diagnosis, and a lot of things lead to FSGS. A good about 10 to 20% of that FSGS, particularly in childhood, and some in adult as well, have genetic causes and they will not respond to any medications, unfortunately. And then they progress on to have CKD and end-stage renal disease, and they would need a renal transplant. Good.
Thank you, sir.
No problem.
Good evening, sir. I have a doubt.
Go ahead.
When will we confer, or when we can come to a conclusion that the child is free of nephrotic minimal change disease?
Good point. Good point.
Is there a criteria?
So, good point. Good point. So if you have somebody with steroid sensitive, okay, you got infrequent relapses in this side, okay, because this is easy, right? Once you have frequent relapses, obviously you are not in, you don't have a cure yet. But if you have infrequent relapses and you have waited about 2 years or so and you don't have relapses, then likely you have a cure.
Thank you.
No problem. Good question. Okay. Anything else? Well, if not, then thank you for giving me an opportunity to talk about our important childhood condition. Okay, great. And
Thank you, sir.
hope to, absolutely. And hope to
Thank you, sir.
Thank you so much.
time later. No problem. Bye-bye.